talk on approach to nodular lymphoproliferations. And just before starting with that, I would like to kind of, briefly kind of talk on a normal lymph node. So lymph node is an organ, is in a state of constant flux. You know that lymph nodes react to any kind of infections. So they increase in size, they decrease in size. But not only the lymph node changes its shape and size, the constituent lymphoid cells also change their shapes and sizes. The various architectural compartments of the lymph node also change their shapes and sizes. Now, as a hotbed of activity of immune reactions, several types of lymphoid cells, stromal cells, including dendritic cells and cells which are extraneous to the lymph node, which means they do not normally belong to the lymph nodes, are also seen participating in the immune reactions. All of this really makes interpretation of the so-called normal lymph node a challenging task. Your familiarization with the dynamic changes that the lymph node undergoes is the key to understand nodal disease. So let's try to understand why are we doing this nodular versus diffuse business. There's a lecture on diffuse lymphoproliferations, and I'm talking on nodular lymphoproliferations. So as a rule of thumb, low-grade lymphomas typically have a nodular growth pattern. They may also have a diffuse growth pattern and typically composed of small to medium-sized lymphoid cells. High-grade lymphoma typically has a diffuse growth pattern and is composed of large-sized lymphoid cells. Now, this is not cast in stone, nothing in medicine is, so you might get variant patterns here and there. But as a general rule of thumb, low-grade lymphomas tend to have a nodular growth pattern. We also use another word called a follicular growth pattern. And typically follicle, you tend to associate by convention with the normal germinal center B cell follicle. So there's a normal counterpart when you call something as follicular. It means it's pertaining to the word follicle, the normal follicle. And that word comes from the Latin folliculus, which means a little bag. When you say nodule or a nodular, it's a small mass of rounded or irregular shape, and it doesn't really have a normal counterpart. The suffix ule actually means diminutive, so something like a duct, you call a ductule. If it's a node, you call it a nodule. So a spherical structure which is slightly bigger than a follicle, but not as huge as a node, you call a nodule. So the talk will focus on nodular lymphoproliferations, but as we go on discussing, we'll also see that there are follicular lymphoproliferations as well. And here's a node which is actually a follicular lymphoma. And when you can associate these things and call them definitely as follicles, what would you call these big structures here? These are definitely bigger than follicles, and this would qualify to be a nodule. But by convention, because we call it a follicular lymphoma, these all would be constituted as a follicular proliferation. So the approach to a nodular versus diffuse lymphoproliferation lies in identifying patterns. So whether it's nodular or diffuse, and if the cells are small to medium or large size, the approach to identifying patterns and cell localization really needs a good low power objective. So basically, if you're going to do lymph node pathology as a specialization or you have special interest in it, you will need a good low power objective such as a 1x or a 2x, because that gives you a great idea on what the proliferation, the architectural pattern is. The non-diffuse patterns include follicular. You can get nodular, as I just said. You can get something which is a mantle zone pattern, which means that it's surrounding the mantles. You can get a perifollicular or a marginal zone growth pattern. You can get PTGCs, which is progressive transformation of germinal centers. There can be interfollicular nodular proliferations, intrasinusoidal proliferations, and there can be a concept of follicular colonization. So there are various patterns. We'll probably try to focus mainly on the nodular and the follicular for the day. Now, there's a caveat again, suboptimally fixed tissue, and that's the bane that we have every day. When the tissue is suboptimally fixed in formalin, it results in nuclear shrinkage. What happens then is that the chromatin becomes condensed and it becomes very dark, and there's an artifactual increase in the amount of cytoplasm. So that's something that we need to keep in mind if there is a tissue fixation problem. Now, how do you approach a lymphoproliferation? There's a histologic evaluation to be done. And this is, I want to emphasize, an essential prerequisite before utilizing immunohistochemistry. It argues against the popular dictum that in lymph node pathology, IHC is the be all and end all. And that's not really correct. You need to analyze, you need to do a morphologic analysis of the lymph node correctly before actually ordering immunostains. You should determine the pattern and evaluate the cytologic features. So you need if it's a nodular or a diffuse pattern, small or medium-sized cells, or there are large-sized lymphoid cells. Then you determine an appropriate differential diagnosis. And on that basis, you will order immunostains or ask for molecular studies. And these will help resolve the differentials and help you render a final diagnosis. So these are the questions. When you have a lymph node slide under the microscope, these are the questions which would come to you. Is there any normal architecture in the lymph node? If the architecture is not normal, is this alteration due to a reactive or a neoplastic process? If it's neoplastic, is it lymphoma or is it not a lymphoma? Non-hematolymphoid neoplasms, you could have a kind of a metastatic deposit of a lobular carcinoma of breast, and that's going to look very hematolymphoid. So you have to look at the chromatin and determine what kind of a cell that is. If the lymph node architecture is altered, the predominant pattern of infiltration, which means it could be nodular, follicular, diffuse, intersinusoidal, and the degree of alteration of the normal architecture, which means is the lymph node involved partially, or is there a diffuse? That means the complete effacement, of the architecture of the lymph node. We need to evaluate all these, and typically you do this at a low power magnification. Now, features associated with low-grade lymphomas include small cell morphology, mature chromatin, absence of a significant number of mitosis or apoptotic cells, and the low proliferation index is assessed by Ki67 or BIP1 immunostaining. High-grade lymphomas tend to show you opposite features. Immature lymphomas tend to be clinically high-grade, but remember that not all clinically high-grade lymphomas are immature or blastoid in nature. Majority of low-grade lymphomas are usually mature in nature. Now, maturity of lymph nodes, the lymphoid cells, is generally determined by the nature of the chromatin. So if you have a fine and homogeneous chromatin with or without a conspicuous nucleolus, this will usually, but not always, be associated with immature blastic or a blastoid nature. If the chromatin is clumped, it's vesicular, or it's condensed, that generally means that it's a mature lymphoid cell. So again, there are caveats here. What happens is, as I said, everything in medicine is open to some kind of a debate. There are exceptions to every rule. So this is the general pattern, but that's not always the case. So here's two pictures for you. This is actually a mantle cell lymphoma, I think. And look at the nuclear chromatin. It's very condensed. You can see even a small nucleus or a chromocenter here versus this, which is a cutaneous deposit of a blastic lymphoma. You can see the chromatin is very, very fine. And you can see this very small nucleoli. So this, my friends, you need to remember, the one on the right is immature or fine chromatin, and on the left is the clumped or a mature chromatin. Determining on the basis of chromatin structure, you will call something as mature lymphoma or a immature lymphoma. So what are the differential diagnoses for lymphoid lesions with nodular growth pattern? So these would include follicular lymphoma, mantle cell lymphoma with a nodular growth pattern. You can have small lymphocytic lymphoma or a marginal zone lymphoma with a nodular growth pattern. You could have nodular lymphocyte predominant Hodgkin lymphoma or a classic Hodgkin lymphoma with nodular sclerosis pattern or a lymphocyte-rich subtype. Very rarely, there is a counterpart to the B-cell follicular lymphoma, which is called a follicular TFH lymphoma, now subsumed under the category of TFH lymphomas, but that's also a follicular lymphoma, which is basically of a T-cell phenotype. For small cell lymphoid proliferations of B-cell lineage, which you have confirmed by immunohistochemistry, the differentials include CLL or SLL. You can include mantle cell lymphoma, follicular lymphoma, marginal zone lymphoma, splenic marginal zone lymphoma, and a remote differential of a lymphoplasmacytic lymphoma that you essentially make a diagnosis on bone marrow. In poorly fixed or suboptimally fixed tissues, Burkitt lymphoma and lymphoblastic lymphomas tend to appear small, so you need to kind of look around for that features as well. So what's the basic IHC panel that you require for small B-cell lymphoid proliferations? Essentially, you need at least some of these markers here: CD20, CD3, CD5, CD10, CD23, cyclin D1, BCL2, and Ki67. And at some stage, I'll go through it as to the individual immunostains and what do they actually mean and what's the importance of that. So coming to CLL, SLL, that's one of the small B-cell lymphomas which expresses CD5. Essentially, CD5 is a T-cell marker. It's expressed by two B-cell lymphomas. One is a SLL-CLL and one is a mantle cell lymphoma. So this expresses CD25 and CD23. It is negative for CD3, CD10, and cyclin D1, and typically has a low proliferation index. You can get both diffuse and nodular proliferations. The constituent cells are small cells with uniform round nuclei. The chromatin is condensed, and the nucleoli are small to inconspicuous in nature. You can also get proliferation centers, and I'm going to show you pictures of that, which are basically pale areas in a dark staining infiltrate. These can contain, these actually contain pro-lymphocytes, which are large cells with prominent nucleoli. Reactive T cells are sparse in this CLL SLLs. So here's a low power view of a lymph node which is involved by CLL, and you can identify this small follicles here, follicles or nodules, whatever you may want to call it. But if you can see at low power, you can see this again. If you can find out this architecture, these are all very small nodules or follicles. So this is a follicular or a nodular growth pattern of a CLL. And look at the constituent cells; they're all uniformly round nuclei, very condensed chromatin, and small nucleoli. Here's another low power view of a CLL involving a lymph node. And while you can make out that there are small nodules here, what's different here is that you can identify a germinal center, a reactive follicle germinal center. So the proliferation is perifollicular in appearance. Now this can actually involve the germinal centers, colonize them, and actually kind of run over this follicle germinal center, in which case we'll start getting a diffuse pattern of growth. Look at these cells again, same CLL cells. So this is a perifollicular growth pattern. And these are all pale centers. These are called proliferation centers. In this very dark infiltrate, it's dark because the cytoplasm is scant. And what you see is also nuclei. And these are all pale centers. And what are these pale centers? They're typically associated with CLL. They're called proliferation centers. And these are full of these largish cells with prominent nucleolus. So these are all called pro-lymphocytes versus the small lymphoid cells of CLL, which are much smaller than these pro-lymphocytes. Remember that cyclin D1 marks some cells in CLL, and these are the pro-lymphocytes. So if you see cyclin D1 staining pattern in a CLL, SLL, that's going to be the pro-lymphocytes in the proliferation center. So that's the counterpart, that's the proliferation center here, and you can see the cyclin D1 reactivity in the proliferation center cells here. This is the immunohistochemistry. What you're seeing is this residual germinal center, which is darkly staining with CD20. Now, typically, CD20 has a very dim expression in CLL, SLL cells. So you can make out here the difference in reaction. It's very bright here, and relative to this, it's dim. CD3, which is a T cell marker, this is negative in the lesional cells. CD5 is positive. If you look very closely here, there are these very dark appearing cells here, darkly marked small cells. These are the normal T cells. And you can still see some normal T cells out into this infiltrate. And it's the lesional cells which show you dim expression of CD5. This sputtering or this sputtering of these small T cells kind of corresponds to the T cells which are also seen in CD3. CD23 by definition is positive. These are the FDC meshworks in the follicle germinal centers. MIB1 staining is fairly low. It's concentrated mainly in this reactive germinal center. In the lesional cells, it would range anywhere from 10% to 15%. And LEF1 is a marker for CLL. LEF1 actually marks normal T cells. So some of these really dark staining ones are the T cells, but the dim positivity is in the CLL, SLL cells. So LEF1 is also a good marker, which helps you particularly in bone marrow kind of CLL, SLL diagnosis. So going to mantle cell lymphoma, this is the other B cell lymphoma, which expresses CD5, which is a T cell marker paradoxically. But here it also expresses cyclin D1, and it's negative for CD23. It's also negative for CD3 and CD10. The Ki67, that's the proliferation index, kind of varies. It varies from very low to very high if you have a blastoid variant, a blastoid which is CD8 negative, or a pleomorphic variant, but it can be very low, ranging from 5 to 10% as well. Mantle cell lymphoma can have a diffuse, it can have a nodular, or it can have a mantle zone pattern of growth. The constituent cells are monotonous, they're angulated, they have cleaved nuclei, but this is one of the lymphomas where the nucleolus is not visible. It's basically absent. So you have an absent nucleolus in a medium-sized lymphoid proliferation with cleaved nuclei. You should think of a mantle cell lymphoma. The other cells that you can actually see in this proliferation are hyalinized venules and epithelioid histiocytes, which can be readily seen. There are two lymphomas we tend to see epithelioid histiocytes readily. Those are mantle cell lymphoma and nodular lymphocyte predominance Hodgkin lymphoma. So here's the low power view. You can see this very pale staining. These are all different sized nodules. This is a high kind of a relatively high power magnification of this nodule. You can see this medium sized lymphoid cells at a higher power. You can see this. These are all cleaved nuclei. You can see this cleaved. You can see this. They are folded. There's a cleft there, and you can see that almost all of these are bereft of a prominent nucleolus, and that's cyclin D1 positivity, which tells you that this is a mantle cell lymphoma. CD20 is positive. CD5 is positive. We need to compare that with 3, and you can see this normal T cells, bright expression, corresponding same bright expression in CD5 as well. The lesional cells are CD5 dim expressing, and that's the nuclear expression for cyclin D1. So that's going to help you call it a mantle cell lymphoma. From there, going on to the third possibility, which is a marginal zone lymphoma. This does not express either 5, 23 or cyclin D1. It just expresses CD20. It's also negative for CD3, and typically it's a low-grade lymphoma, so it will have a low proliferation fraction, either assessed by Ki67 or MIB1. Now again, just as in CLL, SLL, you can get a nodular pattern, you can get a perifollicular pattern. The lymphoma can partially involve the lymph node or diffuse involvement. When it's partially involved, reactive germinal centers will still be apparent. Typically, sinuses, intranodal sinuses are patent in this lymphoma, and that's something which is kind of diagnostic. So if you see that, that's helpful. Otherwise, when you see patent sinuses, it's actually an indication that the lymph node is reactive in nature. But if you see this kind of a pattern, along with that the sinuses are patent, that's a good clue towards it being a marginal zone lymphoma. The constituent cells are pale monocytoid cells arranged in sheets or clusters in perifollicular region and interfollicular regions. In advanced stage, there's a diffuse pattern when the follicles are colonized. So the infiltrate for marginal zone lymphoma is usually heterogeneous. You can get centrocytic morphology, or you can get the very typical round monocytoid cells. Sometimes you can get large immunoblasts also punctuating this infiltrate. Marginal zone lymphomas can show you plasma cell differentiation, and when this plasma cell differentiation is kind of to the extreme end, you can also demonstrate monotypic light chains by immunohistochemistry. So that's very diagnostic for a marginal zone lymphoma. Remnants of germinal centers which lack mantle cups can be identified in the center of the nodules. Now, lymphoepithelial lesions are a feature of extranodal marginal zone lymphoma. You typically don't see them in nodal marginal zone lymphomas. And peripheral T cell lymphoma is a morphologic differential diagnosis based on morphology with all these open sinuses and the medium-sized lymphoid cells. You could think that it's a peripheral T cell lymphoma also, but the CD20 and CD3 will help you diagnose that. So here are some pictures of a marginal zone lymphoma. You can see this remnant germinal center. Note that the mantle cuff is not well developed here. You can see this interfollicular proliferation of medium-sized lymphoid cells. And this is typical for a marginal zone lymphoma. You can see it's tending to become very diffuse. You can see there's some remnant germinal centers. This is one high power view of this remnant germinal center. You can see that the follicle is almost completely colonized by the lesional infiltrate. No mantle can be appreciated. Maybe a couple of follicular dendritic cells in this remnant germinal center, but you can also see this prominent high endothelial cell venule. So that's something which actually makes you believe it could actually also be a peripheral T cell lymphoma. Here's another high power view. You can see in this case, there is not much centrocytic morphology, but more rounded shape, very mature chromatin. And you can see some plasma cells also kind of admixed with this marginal zone proliferation. So if you did a light chain immunohistochemistry on that, you would see some light chain restriction as well. So this will mark with CD20. CD3 is typically negative. CD23 will mark the FTC meshwork. And the Ki67 labeling is restricted to the germinal centers, very low labeling in the actual infiltrate. Here's one more marginal zone lymphoma on a low power. You can make out this small spheres. These are small follicles you can make out. And if you do a CD23 immunoscene as you've done here, you can see these very small germinal centers. And there's a huge interfollicular expansion by a medium-sized low-grade infiltrate. Now, this is how the high power is looking. CD20 is marking the remnant germinal center. Big expression in the regional cells. 23 is marking the FTC meshworks. And you can see that the Ki67 is also limited only to the germinal centers, very low proliferation outside of the germinal centers. And here's what I mean by follicular colonization. So here's the remnant germinal center. This arrow points towards this lesional cells trying to move towards the germinal center inside. You can see that the mantle cuff is not really apparent here. And here you are not kind of able to make out the germinal center because almost all of these cells have now come inside the germinal center. So in this area, if you do a CD23, that's how it's going to look like. The meshworks are all disrupted and all these lesional cells are running right across the follicle germinal center. This is a remnant one where it's trying to invade inside the follicle. So this is what is called as a follicular colonization. So from marginal zone lymphoma, we come to its splenic counterpart called the splenic marginal zone lymphoma. And now this is a rare lymphoma, but accounts for most cases of CD5 negative lymphoproliferative disorders. Again, there's a caveat here. Occasionally, splenic marginal zone lymphomas can express 5, but they'll never express 23 or cyclin D1. The disease basically involves spleen and the splenic hilar lymph nodes. Sometimes the abdominal nodes can get involved. And bone marrow is almost always involved. And the intrasinusoidal pattern of involvement in the bone marrow is almost diagnostic for a splenic marginal zone lymphoma. A peripheral lymphadenopathy is uncommon for a splenic marginal zone lymphoma. You can get villous lymphocytes in peripheral blood. Lymphocytosis is very common. So when you have a marrow investigation, it would not be for a pancytopenia, but for an enlarged spleen and lymphocytosis. The disease can present as anemia or autoimmune thrombocytopenia. And a third of these splenic marginal zone lymphoma cases have a small paraprotein. So this is one of the lymphomas which also has a M band in the serum. So other ones can be marginal zone lymphoma. And of course, you get it with myelomas. The disease has an indolent clinical course, but paradoxically responds poorly to chemotherapy. The clinical outcome is good if you make the patient undergo a splenectomy and give an anti-CD20 molecule, which is called as rituximab. Now, rarely this indolent disease can transform to a DLBL, but it's in a low proportion of cases. Just about 5 to 13% of the cases can transform. The disease marks with CD20, IgD is positive. Very occasionally you can get CD5 positivity, but generally it's negative. It's negative for CD3, CD10, and 23. Cyclin D1 is also negative. Another caveat here, DBA44, which is hairy cell leukemia and marker antigen, also sometimes can be expressed by splenic marginal zone lymphomas. So the neoplastic lymphoid cells are predominantly small to medium size. They're mature chromatin with abundant pale cytoplasm. In the spleen, the tumor cells involve the white pulp in a micronodular pattern and invade the red pulp as well. Nodules may show prominent marginal zone differentiation. And there'll be scattered large lymphoid cells, typically within the marginal zone of involved follicles. These are immunoblasts. So how does this look in the spleen, the white pulp? I think somebody's put annotation request. Can somebody remove this, please?
So just decline there.
Okay. It's not highlighting here because I think I'm on my... Okay, so the white pulp shows medium-sized lymphocytes which surround or replace the reactive germinal centers with effacement of the follicle mantle. This zone will merge with the marginal zone, which consists of medium-sized lymphoid cells, again with dispersed chromatin and pale cytoplasm. So they'll all merge, and occasionally you can also see those immunoblasts or large transform blasts. The red pulp shows infiltration with sheets of small lymphocytes which invade the sinuses. I'm going to show them in the pictures, it makes it simple to understand. Now these are images of a normal spleen. How does a normal spleen look like? So on the left is the H&E image. Typically, the ratio of red pulp to white pulp is 4:1, which is what you are seeing here. Now, the red pulp is congested. It will be made up of sinuses, and the white pulp consists of this lymphoid aggregates. Now, coursing through this white pulp is a central arteriole, and which you can also see here beautifully in the image of CD20 and CDC. That's the central arteriole. You will see this lymphoid follicles attached around the central arteriole. So this black thing marks the germinal center. That's the mantle, I'm sorry. The germinal center is inside, and around that is the marginal zone. And what you can see around this central arteriole are the periarteriolar lymphoid sheath. So that's of T cell origin. So you can see this pals, that is the periarteriolar lymphoid sheath consisting of T cells. And the B cell follicles are much like some fruits hanging from the tree branches. You can see the central arteriole almost like a central bark of a tree, and you can see this hanging B cell follicle. So this is CD20 immunostain. You can see this germinal center and an expanded marginal zone around it. So that's the normal histology of spleen. This is the enlarged view of this germinal center. And you can see this, there is a small mantle which is very darkly stained, and around that you can see a pale area. That's the marginal zone. So here's the mantle, around it is the marginal zone. So this is how it's usually about 6 to 7 layer thick. CD20 highlighting the marginal and the mantle zone cells, better highlighted and delineated by IgD. So IgD, that's a germinal center, and this is IgD, which marks the mantles, and around it is the marginal zone. So the marginal zone in the spleen normally will not be positive for IgD, but when you have a splenic marginal zone lymphoma, it will express IgD. So this is how the normal thickness of the splenic marginal zone is. And here's the SMZL. You can see this micronodular pattern of growth. You can see nodules of varying sizes. Some of them really micronodules, some of them macronodules. So this is the high power here. You can see this remnant germinal center around which this whole marginal zone has subsumed this follicle germinal center. So that's how the morphology looks like. Small to medium sized cells, you can get centrocytic or cleaved morphology. You can get round cells. This is a very mature chromatin, and hardly any mitotic activity to be seen here. Now these are kind of low power images of CD20, and this is IgD. So that's showing you CD20 positivity in the nodules, and so does the IgD. It doesn't mark the follicle germinal centers. So this is the white pulp involvement of of the lesional splenic marginal zone cells. Again, look at the CD20, very bright in the remnant germinal center, but slightly darker in the lesional cells, and that's the red pulp, and you can see this infiltrate inside the red pulp, some of them inside the sinusoids as well. So that's very characteristic and diagnostic. CD3 marks very sparse T cells, CD10 only marking the remnant follicle center cells, CD23 is marking the FTC meshworks and limb expression in the mantle cells. Look at the marginal cells, the lesional cells, which are negative. IgD, again, it's positive not only in the lesional micronodule, but also in the cells in the red pulp. So that's a very useful stain to diagnose splenic marginal zone lymphoma. As far as Ki67 staining goes, it's a very characteristically described target kind of a pattern of MIB1 staining or Ki67. It's target-like because the center, that's the bullseye, is the germinal center, so very high proliferation fraction here. And this thing essentially remains unmarked, and there are scattering of these immunoblasts or large lymphoid cells in the marginal zone, which give rise to this outer ring of positivity. So that's likened or akin to a target board. So that's what it's called, target-like MIB1 immunostaining. Remember that if you have the specimen with you of the spleen, always make an effort to identify the splenic hilar lymph node, because the hilar lymph node is almost always involved by the disease process. So if you have that, the fixation is better versus a spleen which may or may not be well fixed. So here's the splenic hilar lymph node of the same case. You can see the same infiltrate around the germinal center, and having the same immunophenotype positive for CD20 and IgD. 23 is Marco showing something dim expression here. Now, this is the bone marrow of a splenic marginal zone lymphoma. This is an unrelated case, but what I want to highlight here is this lymphoid cells in the sinuses. This is a high part, of course. We can see CD20 beautifully, see the cells coursing through the sinusoids. IgD also marking, highlighting the same. This is very characteristic intrasinusoidal localization of splenic marginal zone lymphoma. You can also get nodular pattern in the bone marrow as well, and sometimes you can even get prominent follicle germinal centers being developed inside this infiltrate. So that's something that you can expect to see. Besides reactive germinal center, you can that's the reactive lymphoid aggregate, which can also show you a germinal center. Splenic marginal zone lymphoma is something where you can actually see a germinal center, and that's not a reactive thing, but it's likely to be neoplastic. Then what will also help you is, again, with this nodular proliferation here, nodular infiltrate rather, you can see this intrasinusoidal localization of these lesional cells on CD20, beautifully highlighted by the B cell marker. So that's something which will help you diagnose SMZL if you have only the bone marrow to study. From there, going on to follicular lymphoma. So as the name suggests, it's the proliferation of follicular spherical structures. By definition, it will mark with CD20, will also express the follicle germinal center markers CD10 and BCL6, and BCL2 is positive in follicular lymphoma. Remember, BCL2 is only of use in follicular lymphoma in the small cell lymphoid evaluation. The follicular lymphoma cells are negative for CD3, CD5, and 23. They can have a follicular pattern, but they can also have some diffuse pattern. But typically, the diffuse pattern will also again consist only of centrocytes. In the follicular pattern, you can get admixtures of centrocytes and centroblasts. Depending on the quantum of the centroblast, the disease is graded, and I'll come to that. Typically, the follicles, the lesional follicles lack tufts of mantle cells. They're seen spilling into perinodal adipose tissue. So here's a follicular lymphoma consisting of different sized follicular shapes, but they all are spilling out, you can see, into the perinodal adipose tissue. That's very characteristic for a follicular lymphoma. A normal lymph node shouldn't be doing that. If you get a reactive follicular hyperplasia, you're unlikely to see follicles in the perinodal adipose tissue. Now, a low Ki67 index in germinal centers favors follicular lymphoma. That's paradoxical. You would expect that the lymphoma will have a bigger or a higher index, but it's the opposite for a follicular lymphoma. In fact, a high index is inconclusive, and I'll show you why. On the right of the screen is a lymph node showing follicular hyperplasia. You can see there's a chock of block with Ki67, and that's expected because that thing is a hotbed of activity. You have so much proliferation going there. And on the left, paradoxically, you can see a follicular lymphoma, but you can see this very mottled appearance of this Ki67. It's very low compared to a normal one. So if you have a low index, that's useful. If it's high, it doesn't help because high can be seen in reactive condition as well as something which is a higher grade follicular lymphoma or a follicular lymphoma of grade 3B. Now that's how you grade the follicular lymphomas. So grade 1 and 2 is graded depending on the number of centroblasts per hyperfield. So if you have 0 to 5, it's called follicular lymphoma grade 1. If you have a 6 to 15 centroblasts per hyperfield, that makes it grade 2 follicular lymphoma. If it's more than 15 centroblasts, it's a follicular lymphoma grade 3. But if you still see some, if you can identify some centrocytes within it, it's follicular lymphoma grade 3A. And if it's just solid sheets of centroblasts, it becomes follicular lymphoma 3B. So I'm just going to show you a couple of this follicular lymphomas. You can make out the follicularity. You can see that even at intermediate magnification, nice, very ill-defined small mantle cuffs here. This is a follicular lymphoma which was low grade. This is what we would call as a centrocyte-rich follicular lymphoma. So this would be grade 1/2. You can see a brilliant, nice follicular dendritic cell and all these cleaved cells. These are all follicle center cells. You're not seeing any polarization here, hardly any centroblast. This is not a reactive follicle, but one involved by a follicular lymphoma. And when it's when it's a follicular lymphoma which is centrocyte-rich, it tends to express CD10 brightly. BCL6, which is also a follicle center marker, is expressed by the follicle center cells. Of late, you have a stain called MEF2B, which is also a very nice nuclear marker for follicle center cell origin. Now, here's a centroblast-rich follicular lymphoma, which you would call as a follicular lymphoma grade 3B. You can see this follicle. There are sheets of centroblasts. You cannot identify any centrocyte amidst this. So this is a follicular lymphoma grade 3B. When it's 3B, the CD10 usually is negative. CD20 obviously will be positive. BCL6 and MUM1 starts to get positive when it becomes 3B. This is BCL2, which by definition you should be getting in a follicular lymphoma. Now, the latest WHO classification does away with a lot of headache, and it's very practical because follicular lymphomas grades 1, 2, and 3A are treated in the same way. Only the follicular lymphoma grade 3B is treated differently. It's kind of treated as a large B-cell lymphoma. So the new nomenclature for it is to just call it a classic follicular lymphoma for grades 1, 2, and 3A. So in the new classification, it's no longer mandatory to grade the follicular lymphoma. You can just call it for a classic follicular lymphoma. But remember that again boils down to you identifying centrocytes and centroblasts. So you might not actually sit and count it and give it a grade. But if you do have sheets of centroblasts, you will call it as a follicular large B-cell lymphoma, FLBL, which is equivalent to the follicular lymphoma grade 3B of the old classification. That's something that you need to remember in the latest classification. Something else to worry about is the presence of BCL2 expressing T cells in the germinal centers. When they are in greater a proportion, then you might actually think of calling it a follicular lymphoma because there's so much BCL2 expression. So always compare the BCL2 with the CD3 also. Diagnosis of follicular lymphoma should be made with utmost caution in children and young adults. There are pediatric variants of follicular lymphomas, but they are exceedingly uncommon. So as a rule of thumb, if you want to call something as a follicular lymphoma in say somebody in their 20s, just be hesitant, just look at it again, maybe even get some of your colleagues to have a look at it or somebody who's more experienced than you to have a look at it before calling it a follicular lymphoma in a pediatric age group. Now, CD10 expressing B cells in the interfollicular region is a diagnostic feature. When you have a reactive follicular proliferation, CD10 expression is limited to the follicle germinal centers, so cells do not migrate out of the germinal centers. But when it's a lymphoma or a lymphomatous proliferation, here's a CD10, you can see the cells outside of the follicles in the interfollicular region. So when you see this kind of CD10 positive cells outside of the follicles, that's also a good pointer towards calling something as a follicular lymphoma. Now, cases, sometimes you might have BCL2 negative by the conventional or the canonical BCL2 stain that we all use, in which case you can actually do a BCL2 with a separate clone that's called a clone E17 that identifies a different epitope on the cell. So if you have a BCL2, for example, this is a follicular lymphoma, but it's blatantly and pointedly negative for BCL2. But you see with this clone E17, that's positive. So I'm not suggesting that everybody keeps this second BCL2 clone E17, but at least the labs which are specializing in hematopathology services need to keep this. And if you do get it and you strongly suspect that something is a follicular lymphoma, you see the CD10 expressing cells in the interfollicular region, but the BCL2 is negative, you can do a MIB1 to help you out. If it's very low, it helps you. And if you have the clone E17, then also it's very useful to call it a follicular lymphoma. So I told you there is a small spin to this. You have a T cell counterpart of a follicular lymphoma. That's the T cell variant of follicular lymphoma, arises from the T follicular helper cells in the follicle germinal centers. And conceptually, that's the early stage of angioimmunoblastic T cell lymphoma. And why do I say that? So here's a lymph node. You can see this germinal center. These are the B cell areas. You can get this T cell areas here. We are focusing on the germinal center in the B cell area. This is the expanded area. You get this bunch of B cells. In this blue are the T cells. And they're all arranged around these dendritic processes of the follicular dendritic cells. And that's where the reaction occurs. The antigen is presented by the T cell on the dendritic processes of the FDC meshworks, and that's where the B cell and the T cell come and live together and reaction, and they give an immune reaction. So this follicular helper T cell, it resides in the germinal centers. PD1 is a marker for follicular helper T cells. This is a germinal center, a normal germinal center. That's the mantle cells around here. You can see this very bright expression of PD1, and these are all follicular helper T cells. Notice that there are hardly any TFH cells outside of the germinal center. Even if they are, you can see that the expression is relatively or comparatively dim as compared to the ones which are genuinely inside the germinal centers. So from the follicle, the T follicular helper cells, you can get angioimmunoblastic T cell lymphomas. But the earlier, conceptually, the earlier stage of AITL would be when it's limited to the follicle only, and that's called the follicular variant. You can also get it in the skin when it's called the primary cutaneous CD4 expressing small, medium, pleomorphic T cell lymphoproliferative disorder. Now, in the latest classification, this is considered a single entity, the angioimmunoblastic lymphoma, the follicular type, and the NOS are all subsumed under this one category of follicular helper T cell lymphoma. These entities are unified by a common genetic landscape. That's the combinatory pattern of mutations in genes which are related to epigenetics and TCR signaling. Now, these changes are common feature of all these nodal lymphomas of TFH origin. Now, why is it important to do this? Is because they show a better response to histone deacetylase inhibitors compared to other PTCLs, highlighting the clinical relevance of the TFH phenotype. So let me tell you that versus a B cell lymphoma, the T cell lymphoma is not a good outcome. So they don't respond terribly well to your chemoimmunotherapy. So this subset of T cell lymphomas respond well to histone deacetylase inhibitors because of the epigenetic machinery which is kind of deranged in this lymphomas. So that's useful to know, and that's useful to actually subtype and tell your treating physician. By definition, this entity is restricted to primary nodal or systemic cases and excludes the cutaneous variants. Now, because of these 2 point mutations, that's Rho A G17V and the IDH2R172 point mutation, these are very characteristic of TFH lymphoma. So therefore, NGS studies are quite valuable in supporting a diagnosis of TFH lymphomas. There are antibodies available to IDH2R172. I haven't used it, so I have no personal experience of those antibodies. So here's the T follicular helper cell lymphoma. You can see this ill-defined small nodules, follicles with lots of pink cells, which are histiocytes. A similar pattern here. You can see this very small follicles at this low power. But this is better accentuated by the CD20 stain. And this is something that helps you, conversely, when you have a T cell lymphoma, a B cell lymphoma, CD3 helps outline the follicles. In this case, it's CD20, which is kind of helping you outline this follicle or a nodule. And you can see the CD3 here highlighted, and you can see this follicles, which are all highlighted by CD3. So this is the very opposite of a follicular B cell lymphoma. So the constituent cells are medium-sized, stipple, chromatin. But what's important is that you can see this, they are accompanied by the histiocytes. You can see this eosinophils, there are plasma cells. So the typical infiltrate of a AITL, that's bang within the follicle germinal centers. These are some big cells and probably FDC meshworks. So here's the immunostaining pattern of this follicular helper T cell lymphoma. They express CD3, CD2. 23 typically doesn't show you lots of extra follicular proliferation. In this case, actually, it is showing, but typically there is a disruption of meshworks and it's limited to the germinal centers or the follicles. Here's CD4, which is also a TFH marker being positive in the lesional cells, CD8 negative. PD1 and ICOS are both markers for TFH cells. In this case, you can see very bright expression of ICOS by the T follicular helper cell lymphoma. Another characteristic finding of a TFH lymphoma follicular variant is that they tend to be stage 1 disease and they tend to be at one localized site. Another thing which is characteristic of them is that they tend to show you lots of immunoblasts. And in this case, CD30 is highlighting lots of immunoblasts in and around the follicle. You can see this PAX5 marking those cells. So that's B immunoblast. And in this case, EBV LMP1 is also highlighting the same proportion of cells. So these are bystander EBV stimulated B cell immunoblasts. So before I hop off to the Hodgkin lymphomas with the nodular pattern, I just want to brief you about the immunostains that we use. So basic IHC panel CD20 and 3 are the most basic stains. It helps find out if the cell of interest is B cell or a T cell. If you do a CD5 next, if the CD5 expression is similar to CD3, then obviously they are T cells. If it's not, then they're abnormal T cells or they're abnormal B cells. I told you the abnormal B cells would be CLL or mantle cells. You can do CD23 and 5, or you can do CD5 and a cyclin D1, and that would tell you if it's a CLL or a mantle cell lymphoma. If the expression doesn't match CD3 and there's a loss of CD5 in the cells corresponding to the CD3 positive T cells, that supports a diagnosis of a T cell lymphoma. Suffice to say that they would be CD20 negative. So what about CD10? That's a follicle with center cell marker, usually positive in low-grade follicular lymphomas, the classic ones. When it becomes 3B, it's unlikely to be positive. It tends to be negative in 3B or DLBL. It's also the common acute lymphoblastic lymphoma antigen, so it marks ALS, acute lymphoblastic leukemias of the precursor B cell phenotype. It also marks blastoid mantle cell lymphomas. And just the way that it marks the germinal center cells, the follicle helper T cells, which I just showed you before this tumor, it can also mark with CD10. So the follicle helper T cell markers include CD10, BCL6, PD1, and ICOS, and CXCL30. By definition, you need to show at least 2 of these 5 markers to be positive to call a T follicular helper cell lymphoma. Now, what about CD23? CD23 marks follicular dendritic cell meshworks and shows dim expression in the mantle cells, positive in CLL, SLL, and it's useful to identify FDC meshworks within the follicles. Cyclin D1, diagnostic for mantle cell lymphoma, but other B cell diseases can also express cyclin D1, notably hairy cell leukemia in the marrow. Myeloma, that's myelomas which have the translocation 11-14 will show you cyclin D1 positivity. Sometimes high-grade large B-cell lymphomas will also show you cyclin D1, but they will never be SOX11 positive. Rarely, you can have a cyclin D1 positive peripheral T-cell lymphoma. Now, again, caveats here are that proliferating epithelial cells at all sites, and particularly if you have a gastric biopsy, where you're actually trying to look for a mantle cell lymphoma, the epithelial cells will express nuclear cyclin D1. So be very careful when you interpret cyclin D1 in an endoscopic biopsy. Endothelial cells will almost always express cyclin D1, so they serve as internal controls, be it in the lymph node or in the bone marrow. BCL2, according to me, it has value only in follicular lymphomas. Almost all of the other lymphomas, the small cell, low-grade small cell lymphomas will tend to express BCL2. So that's not a discriminating thing to call something lymphoma or otherwise. So B cells, BCL2 is expressed in most normal B cells except cells of the reactive germinal center. And therefore, this is the reason it's helpful to call something as follicular lymphoma, because the normal reactive germinal center cells will not express BCL2. It's expressed in most normal T cells also. But a small pointer here that if you get a loss of expression or a dim expression in T cells, that's something which is suggestive of a T cell lymphoma. Again, as I said, the T cells in the follicles will mark with BCL2. So if there are lots of T follicular helper cells, always mark that with compare that with 3 before calling it a follicular lymphoma. A primary follicle is something which has not been stimulated, which means it's just full of mantle cells. Will obviously all express BCL2, because remember, except the reactive germinal center, every B cell will express BCL2. So you need to compare this with IgD staining, because IgD will also, and IgM and IgD mark the mantle cells. So if you see a primary follicle and it's all BCL2 positive, and obviously it will be 20 positive, if it expresses IgD diffusely, that means it's a primary follicle and unlikely to be a follicular lymphoma. P67 has got also important help to use when you have this follicular lymphoma versus a reactive follicle. I showed you those pictures. It's important, it's useful to evaluate for follicular colonization in marginal zone lymphomas. The proliferation centers which are rich in pro-lymphocytes in CLL, SLL tend to have a higher MIB1 labeling pattern in that cells. It's mandatory to do P67 or a MIB1 labeling in mantle cell lymphoma. That's part of the prognostication score. And it's useful when there's an abnormal high proliferation, as in when there's a high-grade transformation from a, say, for a mantle which turns into a blastoid, it's very useful, or a marginal zone lymphoma which has turned rogue and has become DLBL, in which case also it's useful to do the P67 labeling. So the last part of my talk is about these lymphoid lesions with a nodular growth pattern, which are not non-Hodgkin lymphomas, but Hodgkin lymphomas. So in this case, the IHC panel should include CD30, CD15, PAX5, OCT2, 20 and 3 obviously is needed, and CD21, which is an excellent FDC marker. So nodular sclerosing classic Hodgkin lymphoma shows sclerosis and lacunar cells, while the lymphocyte-rich classical Hodgkin lymphoma, which can also have a nodular pattern of growth, will show the similar CD30 and CD15 expressing HRS cells, but the background will be CD20 positive versus 3 positive in a nodular sclerosing Hodgkin lymphoma. Dim PAX5 expression is characteristic of the Hodgkin Lee-Sternberg cells. So here's a low-power view of a very obvious nodular sclerosing process. And all of you know that you get this lacunar cells. This cytoplasm is retracted in nodular sclerosing variant. Nodular kind of lacunar cells, that's binucleate ovoid Lee-Sternberg cell. CD30 showing nice positivity, both membranous and Golgi, dot-like Golgi positivity. That's very characteristic for Reed-Sternberg cells, CD15 is positive in the HRS cells. Also remember that 15 will mark the polymorphonuclear leukocytes. So there are a lot of these things floating around. 15 will be marking them, and you will need to discriminate and find out if the cell of interest is actually showing you CD15 or not. AX5 shows you dim expression vis-a-vis this dark expression by the resident B cell. So that's something that you need to remember for Hodgkin lymphomas. The nodular lymphocyte Hodgkin lymphoma is composed of large nodules composed of small cells. So it's a large nodule but composed of small cells, and these are basically the IgG positive mantle cells which move inwards, usually with no germinal centers. Only very rarely do you get germinal centers at the periphery in a nodular lymphocyte predominant Hodgkin lymphomas. Sometimes you also get progressively transformed germinal centers. Now, this is one of the other lymphomas, along with mantle cell lymphoma, where you get lots of pink histiocytes, and a mottled appearance is created by this pink histiocytes. And the nodules, by definition, have preserved FTC meshworks. So here's a nodular lymphocyte predominant Hodgkin lymphoma, multiple nodules. You can see a very mottled appearance created by the histiocytes amidst these nodules. CD20 showing expression of B cells highlighted by CD20. You can see this garlanding of the nodule by the histiocytes here. So that's very characteristic of a nodular lymphocyte predominant Hodgkin lymphoma. Again, this garlanding of the nodules by these pink histiocytes. So nodular LP lymphoma, Hodgkin lymphoma, will have the pathognomonic popcorn cells which express CD20, OCT2, BOB1. These are all B cell transcription factors. AX5 will also be expressed, but again here also it shows a dim expression. Usually CD30 and 15 are negative. On occasion CD30 may be positive. In the background are T cells. The T cells are mainly CD4 expressing helper T cells over the CD8 cytotoxic subset of T cells. When you have a reversal, when you have more CD8 and CD4, that's typically seen and associated with a T cell rich B cell non-Hodgkin lymphoma. Nodular lymphocyte predominance Hodgkin lymphoma, and now it's just called a nodular lymphocyte predominant B cell lymphoma, and T cell rich B cell lymphomas lie on two ends of a spectrum. Now, FDC meshworks are intact in nodular LP Hodgkin lymphoma as opposed to the T cell rich large B cell lymphoma. So even if you get one or two FDC meshworks in the nodules, that's enough to make a diagnosis of nodular lymphocyte predominance Hodgkin lymphoma. Now, you should think of nodular lymphocyte Hodgkin lymphoma when you're confronted with a big potato lymph node at a solitary site. So it could be in the axilla or the inguinal region where you see a big lymph node. Start thinking of nodular lymphocyte predominance Hodgkin disease or lymphoma. So here's another picture, the very large nodule here, which is involved by this, gives you a mottled appearance by the histiocytes, pathognomonic popcorn-like cells, more of these scattered in a population of these small B cells. And CD20 is positive in those small B cells, but it shows you a differential dim expression in those large cells, better highlighted by OCT2. And IgD also marks the LP cells, but this is commonly seen in younger people. So if the patient is slightly younger on the younger side, 35 and less, then only you tend to see this IgD positivity for an unknown reason, and I don't know the answer to that. It's not seen in elderly people who have nodular lymphocyte predominance Hodgkin lymphoma. Here's one more nodular LP. You can see this histiocytes rimming these big nodules here. And you can see this FTC meshwork by CD21, which is intact here. So these are the lesional cells. So this is a lesional nodule amidst which the FTC meshwork is intact. OCT2 highlights these very beautiful popcorn kernel-shaped, kernel-like lymphoid cell here. MEF2B, I told you, is a good marker of follicle germinal center origin, but it's an excellent marker to mark LP cells as well. So if you sometimes have a difficulty in distinguishing between a classic Hodgkin lymphoma and a nodular lymphocyte predominance Hodgkin lymphoma, sometimes MEF2B can bail you out because it's not supposed to be expressed by the Hodgkin Reed-Sternberg cells. So some hints about these stains that you would use for a nodular growth pattern for Hodgkin lymphoma. CD30, besides marking the Hodgkin Reed-Sternberg cells, also highlights immunoblasts. So when you start seeing big cells with CD30 expression, look at the morphology very closely because they may just be immunoblasts. Essentially, CD30 is an activation marker. So any cell which is active can also show you CD30 expression. CD15, besides marking the HRS cells, also highlights the polymorphonuclear leukocyte. So there's a rich polymorphonuclear leukocyte background with Hodgkin lymphoma. Don't just have a knee-jerk reaction to say that it's CD15 positive. Look very closely what cell, whether the cell of interest is expressing CD15. PAX5 DIN positivity is the sine qua non for diagnosis of classic Hodgkin lymphoma. OCT2 positivity is useful for diagnosis of nodular lymphocyte predominant Hodgkin lymphoma. It marks the mantle cells of the LP nodules in a dim fashion, and it's almost always negative in classic Hodgkin lymphoma HRS cells. CD21, for some strange reason, is better than CD23 at highlighting FTC meshworks in nodular lymphocyte predominance Hodgkin lymphoma. That's been my experience, and I've talked to some of the colleagues who also concur with that. So if the CD23 hasn't highlighted a FTC meshwork in a lymphoma which looks like a nodular LP in a young patient, do try to chase it up by doing a CD21. So I'm going to end here by a small flowchart here. If you have an atypical lymphoproliferation where the lesional cells are in minority, such as with HRS cells, then you would tend to think of a Hodgkin lymphoma or of the classical type or the nodular lymphocyte predominance type. Rarely there's a T cell rich large B cell lymphoma, but it's exceedingly uncommon disease. You don't see them very often. When the lesional cells are dominant and diffuse, then it's likely to be a non-Hodgkin lymphoma. If you see that they are constituted or comprised of small to medium-sized cells in the nodular pattern, then that's typically a low-grade lymphoma. If there are large cells and typically diffuse, then this is usually a high-grade B-cell lymphoma. So that's, I think, all that I have. Thank you for patiently hearing, and I'm happy to take questions now.
Dr. Mehta, please take the question.
So there are some questions which is put up in the chat box.
Sure.
First is, what is villous lymphocytes?
Sorry?
Villous lymphocytes.
Villous lymphocytes are lymphocytes you see in peripheral smear with fuzzy borders, and that's something that is typical for splenic marginal zone lymphoma. So they look like villi on the top of the cell.
Then how to differentiate NLPHL versus T-cell rich large B-cell lymphoma? So that usually will come as a differential diagnosis of this.
That's kind of a complex question, but the simple answer is that you look for FDC meshworks. You look for the background. You look for the background. If it's more CD8 than CD4, it's likely to be a T-cell rich large B-cell lymphoma. If it's more 4 than 8, more likely to be a nodular lymphocyte Hodgkin lymphoma. There's also the question of looking at the clinical history. If it's an isolated small large node in a younger patient, then you would think that it's unlikely to be a T-cell rich large B-cell lymphoma. Bone marrow involvement is uncommon in nodular lymphocyte B-cell Hodgkin lymphoma, but not that you can't get it. But these are soft pointers towards distinguishing between the two entities.
Okay, sir. Any more questions to ask? And one more question has come, sir. What is the difference between nodular sclerosis Hodgkin lymphoma and primary mediastinal B-cell lymphoma?
So these are both arguably B-cell diseases, but PMBL, that's primary mediastinal B-cell lymphoma, is a different disease altogether. It behaves much better than the other non-Hodgkin lymphomas. Theoretically, it's supposed to be arising from the asteroid cell of the thymus, and therefore it expresses CD23. It co-expresses CD23, CD30, and 20. It's got a very characteristic pattern of large cells and a stroma, which is kind of hyalinized. You can see some compartmentalizing sclerosis. You will see some clearing of the lesional large cells. And as the name suggests, it will be seen only in the mediastinum, and I suppose so is nodular sclerosing Hodgkin lymphoma. But typically, CD20 expression will be very bright in a PMBL versus a classic Hodgkin lymphoma.
Okay, sir. One more question, sir. Differential diagnosis of follicular lymphoma versus follicular variant of marginal zone lymphoma. How to differentiate?
Complex things, so you need to check for follicular colonization. You need to do the follicle center markers like BCL6, CD10, or MF2B, and you see how the follicle is infiltrated. So typically when a follicular lymphoma, so it works both ways. Follicular lymphoma can show you marginal zone differentiation, and a marginal zone lymphoma can show you follicular colonization. Now, when you have a follicular lymphoma which shows you marginal zone differentiation, it will still retain some of the GC markers like CD10, BCL6, or MEF2B. The converse is not true for marginal zone lymphoma, which shows you follicular colonization. But rest assured, these are all complex things, and as long as you're able to diagnose it as a B-cell disease, low-grade disease, and you can stop at that. But if you do want to do that, these are the other ways to go about it.
Sir, and one more question is added. A small biopsy was done without IHC. Any clue to differentiate follicular lymphoma from reactive follicles?
Yes, so you can do that, right? You can look for polarization in the follicles. You can look for centrocytes, centroblasts. You can see the dark areas, the small, kind of the light areas. You can check for tingible body macrophages, which you don't tend to see very prominently in follicular lymphomas. The mantle cells, the mantle tuff may or may not be very well developed in a follicular lymphoma, but in a reactive node, surely it will be very well developed. So these are some soft pointers towards it. Sometimes you cannot, swear on something and say that it is, and at that stage, it's not really a matter of just saying whether it's whether it's follicular hyperplasia or lymphoma. You need to do immunostains. That's why I said that if you have studied the morphology correctly, you will need the help of immunostains after that to come at a diagnosis. So it's not just semantics calling something hyperplasia, or I call something on a core biopsy. It does matter to the patient. So study the morphology well, and if need be, then you will have to do the immunostains.
Okay, sir. Then one more question, sir. When to suspect duodenal follicular lymphoma? Any morphological clue is there?
I thought I read something before that about infiltration of fat. In a core biopsy, you're unlikely to see infiltration of the fat. So that's not going to be very helpful. I thought the question before was in a core biopsy. Sorry, duodenal follicular lymphoma it's no different than a follicular lymphoma, but tends to behave in a very indolent fashion. You just diagnose the way that you do with any other follicular lymphoma. But if you want to label it as a duodenal type follicular lymphoma, you have to make sure that there is no regional lymphadenopathy, that it's not secondary involvement by it. And other morphologic clue to a duodenal type follicular lymphoma is that the villi, the duodenal villi will also show you that CD20 and 10 expressing small to medium sized lymphoid cells. So that's a soft pointer towards it being a duodenal type follicular lymphoma.
One more question, sir. Does LCA highlight only neoplastic population or even normal population? It's like normal also will be taken by LCA. It's not like only the neoplastic. It will be highlighted whatever the lymphocytes which are present. Okay, it's a leukocyte common antigen.
Sorry, I didn't get that. Was that what?
No, students were asking whether LCA will highlight only the neoplastic population or the normal population.
Yeah, I think you correctly answered that.
Yes.
Yeah. So if it was that easy, then lymphoma diagnosis would be so much easier. You just put up an LC and you know whether it's neoplastic or reactive. So no, unfortunately, no, that's not the case.
Sir, how commonly you encounter, like in case if you are doing an FNAC of a lymph node and then going for a flow cytometry, low-grade lymphomas, are it very easy to pick up in a flow cytometry, sir?
Mitra, I don't do flow cytometry at all. So I have
Okay,
very limited knowledge, but I have my colleagues who have been doing that. And well, it has its own drawbacks, but it also has its own advantages because
Yes,
when you don't have enough tissue or it's a known case of something, you can actually do it. And even if the population of interest is very minimal, the power of flow cytometry is good enough to pick it up. So,
Yes, sir.
but again, I do not have any personal experience of it.
Yes.
So one more question has come. Large B-cell lymphoma with IR4 rearrangement. Any morphology and IHC clue to diagnose that rearrangement?
Large B-cell lymphoma, what rearrangement?
IRF4, sir. Mamma
RF Mamman, no, there's nothing which morphologically leads you to the diagnosis, except that it's quite common in the Waldeyer ring, so it's in the cervical lymph node region, the oral region, typically seen in kind of more of a younger population. I can give you a pointer on IHC, although you get this expanded follicles, but if it's expressing all three, 10, BCL6 and MUM1, that's something in that region. If you see, it's a pointer towards a MUM1 rearranged thing. But no, there's no morphological pointer which will tell you that this is definitely going to be. But the clinical history, the morphology, and the triple positivity for 10 BCL6 MUM1, that is something which will lead you to that diagnosis.
Okay, sir. Okay, sir.
Well, that's it. No more questions?
Yes, sir.
No more questions. Yes, sir.
I think we can end. They've asked one more question, sir. They've just asked about the role of fish in lymphomas.
Yeah, there is definitely a role of fluorescence in situ hybridization. So, top of my head, we just discussed about this IRF MUM1 rearranged thing. So you would need a fish for that. In large B-cell lymphomas, you would need it for determining the double expressors. So the double expressors, to prove it's a double hit, you might require it. Burkitt lymphoma, follicular lymphoma, so translocation 14, 18, age 14, 11, 14 for a mantle cell. But of course, in this age of cyclin D1 and SOX11, you rarely do 11, 14. But these are some of the instances where that would be helpful to actually do a fish on this lymphomas.
Sir, I think we'll take up the last question for the day. What is the IHC panel for plasmablastic lymphomas?
So plasmablastic lymphomas, I would do an LCA. LCA is positive in that. 138 and MUM1, which are plasma cell markers. 320 by and large will be negative. What I find very useful is not even Paxlovid, but OCT2 is almost always positive in plasmablastic lymphomas. You will need to do an EBER to prove, because about 90 to 95% of plasmablastic lymphomas do mark with EBER. There are other antibodies like BLIMP1. Sometimes I use them. It's a capricious antibody. Sometimes it works, sometimes it doesn't. But BLIMP1 is a good marker to tell you that the cell is post-germinal center and is now committed to the plasma cell differentiation. But LCA, so if you are really resource constrained, LCA and OCT2 and maybe a 130 or MUM1 is a good pointer towards a plasmablastic lymphoma. If you are having resources, then kappa lambda also by in situ hybridization will show you some light chain restriction, so that's useful. OCT2 and BOB1 will almost always mark the plasmablastic lymphomas.
Sir, just one doubt. Will LCA be positive in all cases of plasmablastic lymphomas, sir?
Almost always positive.
Okay, sir. I think we can end the section, sir. Thank you, sir, for your simplified approach for lymphomas based on nodal pattern.